Our next speaker, Andras Legner, is going to talk about Reoperative anti-reflux surgery for dysphagia. Please, Andras. There you go. The green one? Yeah? Go ahead, you can go.
Okay. So good afternoon, Mr. Chairman, ladies and gentlemen. First of all, thanks SAGES for allowing us to present our data today. I'm a research fellow working with Dr. Sumit Mittal at the ESOPHAGEAL Center of Creighton University, Omaha, Nebraska. We have no disclosures. Postoperative dysphagia is common among patients who undergo primary anti-reflux surgery, but it usually resolves spontaneously within 6 months, and only a small proportion of patients require esophageal dilation. However, in up to 5%, the dysphagia persists and further surgery may be considered. The revision usually is less satisfactory. The aim of our study was to analyze the efficacy of reoperative anti-reflux surgery in resolving dysphagia and to identify risk factors for postoperative dysphagia after reoperative anti-reflux surgery. The dysphagia severity was recorded on a 0 to 3 scale. Patients with a grade 2 or 3 were considered to have clinically relevant dysphagia. 106 patients who underwent reoperative anti-reflux surgery by a single surgeon were included in this retrospective study. 92 patients were available for at least a 1-year follow-up. Of those, 50% had significant preoperative dysphagia. With increasing experience, majority of the procedures were done laparoscopically. The operative approach was always individualized. In all but 2 patients, the previous fundoplication was completely dismantled and a complete or a partial fundoplication was done. 15% of the patients underwent Collis gastroplasty for short esophagus. The median operative time was a little over 3 hours with an estimated blood loss 100 milliliters. The median hospital stay was 4 days. Significant decrease in the postoperative dysphagia score was seen in the overall group and also in patients who had significant preoperative dysphagia. 17 patients reported significant postoperative dysphagia at follow-up. Of those, 13 also had significant preoperative dysphagia. Out of these 17 patients, 11 underwent 1 or more esophageal dilation, and 1 patient required further surgery. The univariate logistic regression model showed that the significant preoperative dysphagia, the esophageal dysmotility, and the Collis gastroplasty had at least a weak association with the postoperative dysphagia. Certain combination of these risk factors led to a better understanding of poor outcomes. A significantly higher mean postoperative dysphagia score was seen in patients who had esophageal dysmotility and required Collis gastroplasty compared to the others. The incidence of significant postoperative dysphagia was high in patients who had esophageal dysmotility and underwent Collis gastroplasty, but there was 0 in patients who had Collis gastroplasty but didn't have esophageal dysmotility. The postoperative dysphagia score was higher in patients who had significant preoperative dysphagia compared to those who didn't have dysphagia preoperatively. The mean postoperative dysphagia score was even higher in patients who had significant preoperative dysphagia and underwent Collis gastroplasty. Again, the incidence of postoperative dysphagia was increasing with the increasing number of the risk factors. The multivariate logistic regression analysis identified the Collis gastroplasty and the postoperative dysphagia as risk factors for postoperative dysphagia. So in conclusion, the dysphagia after a primary anti-reflux surgery is amenable to correction by reoperative anti-reflux surgery. But Collis gastroplasty with esophageal dysmotility or with preoperative dysphagia is frequently resulted in postoperative dysphagia. For those patients, alternate surgical treatment should be considered for to avoid this poor outcome. Thank you very much for your attention.